Buenos dias, once again. I'm Dr. Chuck Miller, and I'm here today to talk with you about the endometrioma decision tree. This is especially important to patients interested in future fertility. Today, I'm going to discuss the impact of endometriomas on infertility, the management of endometriomas in the infertile patient, and discuss various surgical techniques for the treatment. Well, here is the endometrioma decision tree. It looks very foreboding, does it not? Well, over the next few minutes, I will try to make this an easy flow. That is to say, with a couple of few pertinent questions, you can understand the literature and know how to counsel your patients with problems related to ovarian endometriomas. We know that 6 to 10% of women have ovarian endometriomas. It's mainly in the reproductive age, and the incidence increases in infertile women. 17 to 44% of women with endometriosis have endometriomas. It's often associated with stage 3 and stage 4 disease. The first question we ask, could the patient have a malignancy? Does that ovary look like it's more suspicious? The risk of occult malignancy in endometriotic cysts is between 0.8 and 0.9%. There have been multiple ovarian case-controlled studies, and interestingly enough, there's significantly increased risk with low-grade serous and clear cell endometrioid invasive cancers in patients who have a history of endometriosis. If we look especially in the Pierce meta-analysis, over 13,000 controls, nearly 8,000 invasive cancers, nearly 2,000 borderline cancers. Indeed, endometriosis, as stated above, was associated with low-grade serous cancers and endometrioid invasive cancers. Also noted in this study was clear cell carcinoma. But there was no association between endometriosis and risk of mucinous, high-grade serous invasive, or borderline ovarian malignancies. So, if there is the concern about malignant potential, one must consider whether to do an oophorectomy and ovarian cystectomy. In that case, one must consider whether to do egg freezing, or in the case of a woman with a relationship, embryo freezing, prior to the ovarian cystectomy, for example, or after the ovarian cystectomy. Generally, we would say, in this case, after the procedure, as there is question about malignancy. Well, what about that patient who has an endometrioma and pain? This was a study done by Chaperone's group looking at 300 consecutive patients with ovarian endometrioma and preoperative pain. They looked at it from a standpoint of multiple logistic analysis. It wasn't the ovarian endometrioma that was correlated to the pain. Rather, involvement of the uterosacral ligament showed greater severity of chronic pelvic pain and deep dyspareunia. Vaginal involvement, lower urinary symptoms, and intestinal involvement, greater severity of dysmenorrhea, and not surprisingly, gastrointestinal symptoms. This is a study done by Kahn, looking at women with peritoneal lesions compared to women without peritoneal lesions. Interestingly enough, of the 269 patients who had positive peritoneal lesions, over 85% presented with the pain, versus without peritoneal lesions, only 38%, less than half, presented with pain. Showing again, like chaperone, it is not necessarily the endometrioma, but rather the peritoneal disease that actually impacts symptoms of pain. Well, what is the appropriate surgery if one does have a patient presenting with pain? These are two randomized controlled studies, one by Beretta involving 64 patients greater than 3 centimeters, and one by Alborzi with 100 patients. In Beretta's case, they looked at the comparison of symptom recurrence. And basically, when cystectomy was performed, as opposed to opening the cyst and coagulating, the cystectomy recurrence was doubled versus the fenestration and coagulation. That is, it took 2 times as long before symptoms recurred in the cystectomy group. Alborzi looked at it differently, looked at it pain recurring at 2 years. With cystectomy, it was only approximately 16%. Fenestration and coagulation, over 50% had recurrence at two years. And you look at reoperation, it was 22.9% in the fenestration and coag group versus cystectomy, far less, 25 or only 25% of what the fenestration and coagulation was at 5.8%. Now again, if you have the ability, ideally you would want to do egg freezing or create embryos prior to surgery because of the concern of the effect of surgery on eggs and egg numbers and egg quality. So, if someone has pain, one looks at size. Literature tells us to look at size. If they're greater than 3 centimeters, consider egg harvesting prior to ovarian cystectomy. Because of the position of the ovarian endometrioma, it may be wiser to do it after, but egg freezing, embryo freezing should be considered. With smaller cysts, one can consider medical management. Now, if there is not pain relief, one can consider surgery. And whether you have relief or not, one can consider egg or embryo freezing. What about that woman who presents to us with infertility and has an endometrioma? Well, we know that guidelines from ESHRE, ASRM, the National Health Service in England, that laparoscopic ovarian cystectomy by excisional surgery for endometriomas greater than or equal to 4 centimeters improves spontaneous pregnancy rates. And you can see that in both Beretta and Alborzi's studies performing cystectomy, that there were excellent cumulative pregnancy rates, with much lesser pregnancy rates with drainage and coagulation. So while the societies talk about greater than or equal to 4 centimeters, you see here that surgeons doing using 3 centimeters as the cutoff showed excellent pregnancy rates, especially with cystectomy. Not only can cystectomy be performed and show success rate, this was a study by multi-center study with Roman as the senior author, looking at ovarian endometriomas greater than 3 centimeters treated via plasma energy, which does not go as deep into tissue. It does not have the desiccation effect of bipolar cautery. So plasma energy versus cystectomy, plasma energy being much more superficial. And you can see that pregnancy rates at 24 months and 36 months were very similar to the cystectomy group. So they would seem to be equally efficacious from a standpoint of enabling a pregnancy. So if someone has infertility, size counts. If it is greater than or equal to 3 to 4 centimeters, I would recommend that egg embryo freezing and then ovarian cystectomy with attempt at pregnancy. If it's less than 3 to 4 centimeters, we generally will attempt pregnancy. And if pregnancy is not achieved in either of these cases, then we would go ahead and consider assisted reproduction. But interestingly, if it's greater than 3 to 4 centimeters, I would consider, looking to do a spontaneous pregnancy, I would consider surgery. Well, now, what about impacting success rate of IVF? And this is probably the most debated topic of the questions that I raise in the endometrioma decision tree. Per ESHRE guidelines in 2014, an endometrioma greater than 3 centimeters should be removed prior to IVF. I can tell you, I can attest for the fact that that is not necessarily what is recommended by many other societies. Now, there is some advantage. Look at this. This was a small study done by Kochia. And I want you to look at the implantation rate. This is women who had endometriomas less than 30 millimeters versus endometriomas greater than 30 millimeters. Look at the difference in implantation rate. Doubled implantation rate in the smaller endometrioma group. Look at the clinical pregnancy rate that you see here. 16.7% versus 26.2%. And look at the clinical pregnancies, 2 in 12 versus 11 in 52. Certainly, a larger endometrioma would appear to be more problematic. Now, many physicians are very concerned with surgical excision of an endometrioma. We know that there are many publications, including 2 recent meta-analyses, showing decrease in AMH, so decrease in ovarian reserve post-surgery can be up to 9 months. This can happen in the case of unilateral and bilateral ovarian endometriomas. Unku found that while there is a decline in AMH, is progressive, it is worse in patients with bilateral endometrioma surgery. Alborzi found again it was more significant a decline with bilateral endometriomas. Kwan noted significant AMH decline with bilateral ovarian endometriomas, or specifically large endometrioma greater than or equal to 5 centimeters. So the cyst size can make a difference. Now, why does a cystectomy worsen ovarian reserve? Well, The thought is, number one, you're removing healthy ovarian cortex. Roman looked at a retrospective study of 38 cystectomy specimens in 35 women and found a direct proportional relationship between the endometrioma size and ovarian parenchyma removed. Greater size, greater loss of parenchyma. Matsuzaki noted that ovarian tissue on excised endometriomas was 10 times more frequent than other benign cysts. Think about removing a dermoid or removing a serous cystadenoma or mucinous. We know that those cyst walls can be removed very simply. On the other hand, ovarian endometriomas are oftentimes very difficult to excise their capsules. So this may, in fact, be the cause of this increased loss of normal ovarian tissue because of excision of the endometrioma. And finally, Romaldi, looking at younger women, noted that their smaller cysts were associated with more follicle loss than an older woman. So just the population you want to be as meticulous as possible with doing ovarian endometriomas. Smaller cysts were associated with greater follicular loss. There can also be thermal damage to the ovarian parenchyma. This was a study by Samigliana. 9 of 11 studies showed AMH reduction post-surgery, especially when bilateral energy was performed, period. And in this study, interestingly enough, 10 to 11 studies that Samigliana put together, 10 of 11 utilized bipolar energy. So this is especially damaging to the ovarian parenchyma when you desiccate with bipolar. And another reason why against surgical incision is that surgery can be related to local inflammation. And we know that local inflammation can have a negative effect on endometriosis. Now, remember I was talking to you about the fact that there was concern about AMH and surgery, but we have to also look back at some of the recommendations. I mean, we know that bipolar can really impact ovarian reserve because it follows the path of least resistance, and therefore it can impact negatively the blood supply to the ovary. And look what happened. Virtually all these cases were bipolar. It's not surprising, therefore, that there were such dismal results. Now, other people have recommended, we talked about excision, we talked about plasma energy. How about the use of ethanol sclerotherapy? Now, this sclerosing technique in this paper used 100% pure ethanol sclerosing agent. It was instilled 2/3 of the aspirate, not more than 100 cc's, and let it remain for 15 minutes. In this case, the installation was compared against cystectomy, where a monopolar anti-mesenteric incision was made, and then the capsule dissected out. But look at what they did. Bipolar energy for bleeding. Obviously, you didn't have to deal with bipolar in the sclerotherapy group. If you look back at recurrence, there was more recurrence in the cystectomy group. Half of them, interestingly enough, were contralateral. So I don't know how much that really should be a factor. But there was only 6% with the sclerotherapy group. Now, while there was not recurrence in the sclerotherapy group, the authors felt that this was time dependent, because in the sclerotherapy group, again, installation was for 15 minutes, where in another study, it was done only 10 minutes, and there was a much greater recurrence in the sclerotherapy group. Again, back to plasma energy. This is looking at antral follicle count on the operated and non-operated ovary. And you can see that there's very little difference when you compare post-plasma energy treatment. This was a study by Muzi, and was a multi-center group where patients went ahead and removed a portion of the cyst wall and then desiccated the base. Again, I come back to bipolar is bad. And you can see that interestingly enough, that the stripping side actually did better than the desiccation side from a standpoint of the ovary itself. There was better ovarian volume. There was better at 6 months antral follicle count in terms of the using the stripping side. A 3-stage technique has also been recommended, where this is by George Patos's group. In stage 1, laparoscopy and fenestration was done. Then the patient was treated with a GnRH agonist for 3 months, followed by laparoscopy and ablation of the cyst wall. Not excision, but ablation. There were 3 randomized let's try that again. The randomized controlled trial of a 3-stage technique versus stripping, in this case, there was better antral follicle count and AMH with the 3-stage techniques, but the concern was small sample size and recurrence with the 3-stage technique. In this study, Group 1 was stripping, and Group 2 was the 3-step laser vape. And as you can see, the AMH was higher in the follow-up of the Group 2. Moreover, and that was seen to be significant. You could say the same things for changes of FSH in the group. So showing that indeed there was less impact on ovarian reserve in the 3-step laser vaporization group. The problem with this is that it is expensive and time consuming. Jacques Donnet came to us with a surgical technique where you use laser to vaporize the base of this. And Dr. Donnet, especially if we look at the lowest in terms of stage right, if you compare the antral follicle count in the combined technique versus the contralateral normal ovaries, there's virtually no change, So this is certainly a technique that can be used. I have to tell you, I tried to emulate Jacques' technique and was not able to do it. I got into time and time again issues where I wasn't controlling the bleeding well, and I felt I was doing too much energy. So we've damned bipolar cautery. We know that lasers can be problematic because it's expensive, and these multiple procedures get to be really expensive when you're doing this 3-month technique. On the other hand, one can deal with lowering the use of energy for the endometrioma. This was looking at studies of AMH, and as what you see here, that nearly 2 in 3 showed that suturing of the ovarian capsule will conserve AMH more effectively than will desiccation. In the studies, one can see there was greater drop in the AMH than with sutures. If one looks at it not from AMH, but rather antral follicle counts, looking at 7 studies, nearly half postoperative evaluation at 12 months was significantly lower, but it wasn't as low with the suture group than the coagulation group. Now, this is a study by Atta looking at meta-analysis, 3 randomized controlled studies, 1 prospective. And in these studies, he looked at 2 comparing bipolar desiccation and doing a hemostatic sealant, I call it biocoagulable, or 2 comparing the bipolar with suture. And in this group, you found that whether it was the sealant or suture, there is a lower decrease in ovarian reserve. In our experience, we have found there's actually a lower risk in terms of using the biosealant. In this case, we use Tisseal. Not only does it not impact the fibroids as negatively, but it also helps reduce the number of cysts, hemorrhagic cysts that occur in the ovaries post-surgery. We hardly ever see that now with using the Tisseal. This is a study looking at 60 to 65 patients using hemostatic sealant, and there was a fair question in terms of concerns with sealant, in terms of viral transmission, although no reports, it's purely theoretical, thromboembolism, and adhesions. This is a study, so do we do well without having to remove the ovaries? Well, this is looking at a number of practitioners, and you can see that these patients did very, very well. But the fact is, look at the size of the endometriomas. There's not going to be much difference between the ineffective side and the effective side when you're dealing with cysts that are that small. This is a study by Ferraro looking at, interestingly enough, endometriomas greater than 5 centimeters with a healthy contralateral ovary. This retrospective management can show that not only are you going to have, with this size endometrioma, you are definitely going to have a lower number of endometriomata, lower number of oocytes retrieved, lower number of follicles, lower numbers of oocytes retrieved, and finally suitable oocytes. So a meta-analysis that was done by Hamden showed that if you compare surgery to non-surgery, matchup is quite good. In terms of live birth rate, clinical price rate, miscarriage rate, cancellation rates. But we do know on the surgery side, there will be decrease in antral follicle count and number of follicles that are retrieved. So it does show that there can be activity on the ovary. It just not looks to be a major concern. These are similar to what thoughts were by Tao and Nico Amory in 2018. So if there is assisted reproduction, Consideration can be given to performing surgery because of the inflammatory nature of endometriosis, ovarian endometriomas, but also one can proceed directly to assisted reproduction, as long as, again, questions you have to ask. Is the patient at risk of endometrioma rupture? Now, this would be the case where you're going after follicles, you're going through the vagina into the ovaries to take out cysts, and you have endometriomas. All of us know that if there is infection in an endometrioma, it can basically wipe out ovarian function in that ovary. So if it looks like the retrieval will be more difficult, and it can be oftentimes, here's a study where the frequency of non-complete follicle aspiration was more than 3 times higher with endometriomas, that people skirted those endometriomas. I submit to you that those patients, perhaps if there's a problem with discrepancy, that they have their endometrioma removed. Besides having the problem in terms of more difficult retrieving, there can be problems with contamination of the follicular fluid, which can occur when you're in the process of taking out the eggs. And that can lead to terrible pelvic infection and abscess formation. So if one is involved in assisted reproduction and there is a risk of rupturing at retrieval, then one would go ahead and do an ovarian cystectomy, then go on to do the art. Well, the next question is, so we can go ahead and get access to that ovary. The patient's infertile, we want to do IVF or we want to do ICSI, potential with pre-implantation genetic screenings. But how does a low antral follicle count? What should we do about a low antral follicle count? Well, we know that there may be some excision to going ahead and removing the cyst. We know that the cyst stretches ovarian cortex, and the loss of follicular density secondary to the increased oxidative stress, we find that the ovarian organ surrounding the endometriomas will be in fact impacted. There will be a loss of follicular density. A second thing that happens is we know that there are free radicals within the endometrioma, and that can cause a gonadotoxic insult to follicles adjacent, basically what you call a burnout hypothesis. Endometriomas cause local inflammation in the ovarian capsule, which leads to fibrosis and loss of cortex. The inflammation and associated decreased vascularization, increased oxidative stress may lead to enhanced follicular recruitment. So in the process of having the inflammation, vascularization problems, oxidative stress with that occurs, it may end up causing problems with follicular recruitment. Further, we know that endometriomas do lower the antral follicle counts more than different cell types. Finally, Osgood noted significantly lower antral follicle counts on endometrioma side and lower median number of inserts retrieved. So it does, oftentimes you cannot get all the follicles out if you're trying to be very conservative. So if someone has a low antral follicle count on their affected side, I know I'm not going to do much better. So that is someone that I would go ahead and take the surgery. Implantation failure. Is there a correlation of implantation failure? If someone has long-standing implantation failure, should we go ahead and remove their endometriomas or endometriomas? Recurrent pregnancy loss. In 1994, Simone noted that embryos created from donor oocytes exhibited a significantly lower implantation rates. Now, the thought was that it was due to secondary to the alteration of the oocyte, but we didn't know. There's a theory on implantation failure that we know that endometriosis is an inflammatory condition. It does impact endometrial receptivity. So if there's with more inflammation in the body, there's more of an impact on implantation. This is associated with increase of local and systemic cytokine expression. Now, endometriosis is also felt to be not only an inflammatory condition, but a progesterone-resistant disease. That is, you get a blunted or inadequate response to progesterone. You will see an increase in cell proliferation and survival. There can be elevation of the receptor, estrogen receptor, again, causing this problem with progesterone resistance. And finally, the endometriosis causes defects in decidualization, which may be a fact. At the end of the day, incidental treatment is not recommended except in the case of repeated response or implantation failure. So certainly we know that someone is not responding to non-assisted reproductive technology. That patient goes to ART, goes to IVF. And indeed, we want to look in terms of different things, the size of the mats, whether we can get at the ovarian tissue with the mass in place, or is there going to be an impact in terms of the antral follicle count? If there is a marked discrepancy in antral follicle count, it may be better to decide to remove the tissue early on to see if the ovary will bounce back. So if there is implantation failure, we have already stated that there can be this estrogen dominant response to inflammation, the progesterone is lower, that ultimately if there is implantation failure, we would go to ovarian cystectomy if we can. Advising consideration of egg freezing as needed. If that patient does not have problems with implantation failure, then I would not recommend going ahead and doing the procedure. So finally, as I finish, I know I've thrown a lot of information at you this morning. This is I would say it's quite a nice review that just came out in JMIG, and as surprisingly, the endometrioma treatment paradigm with fertility when fertility is desired, a systematic review. I thank you for your attention.